Hello everybody and welcome to our webinar. I'm Emily Crossley, co-founder of DUCHENNE UK and mum to Eli with Duchenne. My co-founder Alex Johnson is also on the line, but unfortunately today she's suffering from some major wisdom teeth pain. So she's pulled herself out of her sick bed and has very kindly agreed to field some questions later. But we're going to try and keep her contributions to a minimum, poor thing. So thank you for joining our latest webinar. And really, we launched this series to try and give you some comfort, reassurance, and factually useful knowledge that you can use in these unprecedented times. And today we're going to get to grips with the question of steroids, the adrenal system, and what is emergency stress dosing. And we're very pleased to be joined today by Dr. Jarod Wong, who is the clinical senior lecturer and honorary consultant at the University of Glasgow, who's kindly agreed to answer our questions. So today we're going to focus on a key number of areas. What are the adrenal glands and what do they do? An explanation of why boys with DMD on steroids have adrenal suppression. We're going to explore what's meant by stress dosing of steroids and when they might be needed. We're going to cover off some issues about who may or may not have been contacted by their neuromuscular centres about stress dosing. And we're going to give you some advice on how you can explain to doctors who aren't familiar with DMD what they need to know. Like last week, you can ask questions using the Q&A button in the Zoom toolbar. And we're going to try and answer as many of those questions as possible, but we'll leave them until the end of Jarod's presentation to avoid repetition. So Jarod, first of all, thank you so much for joining us during these very challenging times. You're very welcome on our webinar. And why don't we kick off with going back to the beginning, really. And if you could start off by explaining what the adrenal glands are and what they do.
Thank you very much, Emily, Alex, and DUCHENNE UK, and welcome everybody to this challenging time. And the idea today is to just give you some information, so hopefully you have a better understanding of the issue of adrenal suppression in boys with DMD treated with long-term steroids, which might be much more relevant in the current COVID pandemic. So as an endocrinologist, I kind of like to talk about glands. Glands are organs in the body which makes lots of products called hormones, and hormones have got effects on different parts of the body. The gland that we're talking about today, and you can see that in this picture on the left, is the adrenal gland, which are two glands which sits on top of the kidney. The adrenal gland makes different sets of hormones, and one of the set of hormones, in fact, actually is natural steroids. And all of us make a certain amount of steroids, and steroids are very important to keep us well, help us maintain good energy levels, but also to help us to fight infections. And in all of us who are not taking high doses steroids like boys with DMD, during times of stress like infection or surgery, the body knows how to make more steroids that's needed to cope with that sort of stress. The adrenal glands is under the control of another little tiny pea-sized gland that sits in sort of in the brain called the pituitary gland. And the pituitary gland is in fact actually the master regulator of all hormone controls in the body, including the adrenal gland. So this essentially is what the adrenal gland does. It makes a whole set of hormones, but most importantly, steroid hormones, which are important to keep us well and to help us cope with stress, including the stress of infection. Secondly, why do boys with DMD on high-dose steroids have adrenal suppression, therefore? So I tend to sometimes use a sort of a simplistic way to say that the adrenal glands have gone to sleep because the dose of steroid that boys with DMD take are probably in excess of about 5 times of what the body would normally make. The body is an intricate machine, and when there's such high doses of steroids in the system, what happens is that it switches off the signals that the pituitary gland, which is the master regulator of all hormones, so that in fact it tells the person's adrenal glands to stop making their own natural steroids. So therefore, if somebody takes prednisolone or deflazacort in the doses that boys with DMD take for a few months, at least about three months onward, the adrenal glands would go to sleep, mainly because that high-dose steroid is telling the pituitary gland to switch off the signals. So therefore, boys with DMD on long-term steroids have what we call adrenal suppression. and there is no problem with the gland itself. So in a sense, or if the boy with DMD who takes daily steroids continue to take steroids, this is absolutely fine because there's no problem, okay? The majority of boys with DMD who take steroids at the doses are prescribed should be able to have enough steroids in the system to cope with mild and moderate infection or mild moderate stresses, but may not be sufficient for much more severe stresses and infection. And I think the next slide will go into those situations. So let's get back to that whole issue. So we know that the adrenal glands make a certain amount of steroids, that in somebody with no adrenal suppression or issues with adrenal glands, in mild to moderate illness, it makes about 3 times more steroid hormones. And I've already mentioned that the majority of boys on daily steroids who take the doses that are prescribed, it's in excess of about 5 to 6 times, and some even more, depending on the dose that is prescribed. So in other words, during mild to moderate illness, if a boy with DMD is on steroid and continues to be able to tolerate steroids, that dose is sufficient to cope with infection. There are some older boys, and particularly adults, when the dose of steroid is reduced following loss of ambulation, the dose that that young person takes may not be enough to cope with the stress of mild to moderate illness. And in those instances, these boys may need a plan of, for instance, increasing the dose of steroids or perhaps taking it a couple of times a day. And in a small number of boys with DMD, particularly older non-ambulant boys and adults, this whole issue of taking more steroids during mild to moderate illness is important. And this is what we mean by stress dosing. So taking more steroids during stress or infection. Now, a lot of you will know about the whole issue of the hydrocortisone pack or the steroid injection pack, and we are aware that this has now, there's more recognition of the need of that. And there's still some confusion of when this is needed. So steroids that boys with DMD take, especially younger non-ambulant boys, will be sufficient to cope for mild to moderate illness. But of course, if the young person has a vomiting illness, or vomiting and diarrhea, for instance, gastroenteritis, the child will not be able to tolerate steroids, and injection of steroids should be considered prior to presentation to the hospital. And in some centres, these hydrocortisone injection packs are at least dispensed for families to have at home and school. In some centres, these patients are actually taught how to inject hydrocortisone at home. And I've listed some information that you might find useful. On the right is our neuromuscular nurse specialist, Jen Dunn, who's made a video on this particular topic and how to inject intramuscular hydrocortisone, which you can look at. On the left, a series of different videos from the Addison Society, which is a rare condition with the adrenal gland, but they have made some useful videos on how to inject. There are also differences in the kind of hydrocortisone packs which are available. The ones that we prefer to use are the ones we are already pre-mixed. But in the last year or so, we are aware that there have been some shortages in that, and we have to dispense some of the ones where it is a powder and the family have to mix them. And the Addison Society give you some information on that, which you can have a look at if you're interested. The MyCortisol app, which I'm aware is used quite widely in quite a lot of hospitals. It's not just for boys with Duchenne's, it's for boys with all kinds of children with adrenal issues, which will have useful information as well. So just to summarize, stress dosing by increasing the doses of steroid tablets is needed in people with adrenal suppression or adrenal insufficiency, but the doses that the majority of boys who are ambulant should be sufficient to cope with the stress already and may not be necessary. But older ambulant boys and adults, there may be a need for a plan to increase oral steroids during mild to moderate illness. The injection is when there's diarrhea and vomiting, or if the child is very unwell and very floppy. Now, in this current COVID pandemic, the injection issue perhaps maybe less of an issue, although I'm aware that there's probably a small percentage of symptoms of patients who are COVID positive who do have diarrhea. So I guess as long as we're aware of the issue, and if you've not been dispensed with that, don't panic. You should just be aware of this issue and call an ambulance if you think your child is that unwell, and we can discuss that later on. Next slide.
Thank you so much, Jarod. That was very clear. So we'll go now to the final two areas that we want to discuss. And perhaps if you could start off by clarifying why some of us may have been contacted by our neuromuscular centres about stress dosing of steroids. Have they been doing that specifically because of COVID-19? And one thing we're hearing from the community is that different centres are sometimes giving different advice.
Yep, thanks, Emily. I think that's a very useful question to address. So I think patients and families would really like all centres to be doing the same thing. And I think over time, there's a lot of recognition, at least in the UK, that we're trying to streamline care and implement standards of care. So not everything exactly identical yet. And even with treatment of steroids, we know that there are different ways of giving steroids, different types of steroids on regimen. The issue of adrenal suppression and adrenal insufficiency is something that's not a new thing, but I think at least in this population has not been addressed as well as we should. And I think we all should take responsibility for it, including clinicians. And the emergency plans may not have been implemented in every single centre. And that's something that will be addressed and is being addressed UK-wide between patient organisations like DUCHENNE UK and also clinicians in the North Star and other endocrinologists. Now, because it's not, some of you may have received letters of changes in your emergency plan, or in fact addressing the issue of an emergency plan for the first time in recent weeks, for instance, or you may get that coming soon. And it's not because we think that COVID-19 is anything much more specific that we need to actually tailor the emergency plans to. However, some centres have not implemented these plans, not discussed this issue. And if you've got a large centre, you want to actually get the message out to all patients to ensure that you don't miss any patients. So it is possible, there are some centres, despite what I said, that the doses of steroids that a younger boy with Duchenne is taking should be sufficient to cope for stress. But if you've got a large centre where you've not discussed this issue previously, in this current issue, in this current climate, some centres have just sent a standard letter to all families to ask them to have an emergency plan of increasing steroids. There are different ways of doing things. Some of you will be asked to double your steroids. Some may be asked to give doses of steroids twice. At least one London centre use a more shorter acting steroid by tablet called hydrocortisone, which is given about 4 times a day. These are all entirely valid methods. So please don't stress if you think that you've got a family who's treated in centre X who've been told to do something different, or centre Y that's told me something different. We're all just in such extremely stressful and challenging time to keep all our patients safe, but the message is out across swiftly, because we're also losing lots of staff to illnesses and isolation. In due time, I think there is interest between clinicians and also patient group to see if we can actually develop at least a UK-wide consensus of a small number of emergency plans, if not one single plan. The other thing to actually mention as well is that if you've not been given a hydrocortisone pack or injection pack, practically speaking, that's probably not as much of an issue as long as you, in this current time, as long as you know what your emergency plan is, and that the fact that adrenal suppression from long-term steroids is an issue. If you're an older adult, if you yourself or you've got a son who's an older non-ambulant adolescent, particularly an adult with Duchenne, and you've not actually been told about an emergency plan, and you've not been contacted in recent time, there will be a case to actually contact your neuromuscular team in the next week or so, just to make sure you know what your plan is. So hopefully that addresses the issue about differences and why some of you have been contacted in recent time, to hopefully not stress all of you about differences in treatment.
Thank you so much for clarifying that, Jarod. Let's go on to your final slide now on this issue about how can we explain to doctors who aren't familiar with DMD about the issue of steroids?
Yeah, so that is always the issue that I think a lot of you would face with, right? About telling a doctor who's not familiar with DMD, who may not have seen a child with DMD, about some of the issues which are more specific to DMD. It is a challenge, and as much as we try to educate lots of doctors, do lots of seminars and things, it's impossible to educate every single doctor and about rare conditions. So one of the main things, and I suppose the beauty of such webinars, that we're trying to teach you and empower you so you have the right information to tell the doctors which are not as familiar with. Some suggestion of methods that you actually can do. There are various different emergency alert cards by different organizations, and sometimes hospitals issue specific alert cards about your condition, but you do need to make sure that it talks about the issue of adrenal suppression. I am aware of some excellent clinicians in the UK who copy all their clinic letters, listing all the problem lists and copying it to families. You could bring that to an emergency setting if you present. And what is important is that, and I certainly know of some clinicians who clearly give the problem of adrenal suppression as a result of long-term steroid in what they call the list of problems that a child has, and that's very important. But I guess as much as it seems as if like I'm telling you to do the work, but of course all of you will be aware that very often it's in fact actually the family who has to tell the doctor who's not familiar with Duchenne about a particular issue. And one of the things that I'm very, very keen to actually do this webinar and stress this out there is that perhaps, so if a child with Duchenne or a young person with Duchenne presents to hospital or is admitted to hospital with either suspected COVID-19 or possible COVID-19, you would know of all the other extra things that has to be done. There's quite a lot of things that doctors have to worry about, which are all appropriate, all the protective gear and lots of other medicines and treatment that that person might need. But it is very important that we actually tell these doctors that the steroid treatment during emergency is not the last thing on their minds, okay? And this is kind of like an acronym, a mnemonic for you to perhaps remember that. Don't just remember last. And it is actually really something that I've put together to at least, those are important keywords you can tell the treating doctor, because those words will alert to them that actually you do have a problem with adrenal suppression. So you tell the doctor that these are the 4 keywords. You tell them that the boy with Duchenne has been on long-term steroid treatment and therefore has adrenal suppression, and he is therefore steroid dependent, and they do need to treat with extra steroids when unwell. So last, think of long-term steroid treatment, they have adrenal suppression and are therefore steroid dependent, and those doctors need to treat with extra steroids when unwell. So hopefully these are some tips which can help you to relay that information to doctors, not just during the COVID-19 pandemic, but perhaps, which hopefully will be useful also in any other doctor encounter or emergencies in the past. There are various different hospitals will have various different information that has been developed, and a lot of you may know of a specific steroid protocol for emergency, which was developed in between patient organizations in America and some clinicians, called the P.J. Nikolov steroid protocol. It is published in a medical journal. It has got a specific recipe of what to do, but bearing in mind, all hospitals have got their specific protocols of what to do during emergency when somebody has adrenal suppression. It does have, I think the link that we gave is in fact actually a patient-friendly version of that particular medical journal. So if you're interested, you can have a look at that. If you do present to a hospital, it may be in the future, if you're on holiday, for instance, in another country, and they're not even aware of how to treat adrenal insufficiency or adrenal suppression, you could actually point those doctors in those countries to the PJ Nikolov steroid protocol for emergency in Duchenne's muscular dystrophy. Again, don't be confused, don't worry, it may tell something quite specific. If you've been told something slightly different, it's, at least in the UK in large centers, this is essentially okay. It's just another way or another recipe of, in fact, actually managing in such situation. So hopefully this summarizes some ways that you can think about, and it's useful to think of these things prior to an emergency happening, because then you're all prepared.
Jarod, thank you so much. And I think it's testament to the comprehensive way in which you've approached this subject that we actually don't have any questions. And in fact, people who did text us with questions have said that they've been answered. So thank you. But there was one question we had before the webinar, which we thought was worth putting in, because it's just a point of clarification, really. If your child is on a 10 days off, 10 days on regime, or whatever regime they're on, do they still need to have a stress dosing plan in place?
Yeah, so thank you, Emily. I was going to address the 10 days on, 10 days off in my slide, but thought it might actually make more sense to that there is a question to address this separately. So some of you will be on daily steroids, and all that I've told you sort of, I suppose, is catered towards daily steroids. But the issue of adrenal suppression should also be considered in those on 10 days on, 10 days off. Now, it is possible that in the first few months on 10 days on and 10 days off, there is no or little adrenal suppression. There is currently no data, but if you ask the opinion of almost all endocrinologists, if a boy has been on 10 days on, 10 days off for more than a few years, and in actual fact, this boy potentially 5-6 years of 10 days on, 10 days off, we have to assume that there is adrenal suppression. So what do? You still need a plan, okay? And you need a plan on what to do when you're on steroids, and you need a plan of what you need when you're off steroids. And again, different centers will have slightly different approaches, but if your son is on a 10 days on, 10 days off, and he doesn't have an emergency stress dosing plan in place, especially on the days off, I would recommend that you get in touch with your neuromuscular clinician to discuss what the plan is. An emergency pack should also be recommended, but in the current climate, I suppose if you don't have an emergency steroid injection pack as yet, what's more important is actually to ask about the stress dose oral dosing plan when your son or you are slightly unwell with a fever and able to take steroids, but knowing what to do when you become sicker. So I think the issue of 10 days on, 10 days off is something that does need to be thought of. And whilst there's no data to support it one way or the other, a lot of us will believe that there is an adrenal suppression issue. And given the consequences, it's better to actually ensure that we cover the child safely.
Jarod, thank you so much. I'm actually going to bring Alex Johnson in now, because I think we have had another question come into us, yeah. Alex.
Yeah, just one point to clarify, Jarod. Does the same advice apply to young adult girls who are ambulant manifesting carriers? Should they also follow this advice?
I think if they're on steroids, my advice will be, I must say, I don't have experience with any carrier girls on steroids. I'm only assuming that the doses are used similarly, but I don't actually have experience. That's a good question. But if it's a girl who's taken long-term steroids and at the doses that are used in boys with Duchenne, there should also be an issue that needs to be brought up with the neuromuscular team.
Yeah, thanks, Jarod. They have just clarified it's 17.5 milligrams per day, 10 days on, 10 days off that the young lady is on.
Yeah, so I would recommend that they actually discuss with the neuromuscular clinician.
Great, thank you.
Okay, thank you so much, Jarod. Well, I think you've done an excellent job of covering all those topics for us. And as we've got you for a little bit longer, we thought we might question you a bit more on some other issues that come up to us from families, and that's really the impact that steroids can have on boys' development. So we often get asked questions about the impact on how steroids affect stature and growth. And so we basically pulled together a slide which has an infographic showing what the recommendations are according to the most recent standards of care. You can find this on our website. But in terms of steroids and their impact on growth and height, can you talk us through this infographic and just explain what patients need to look out for, and if indeed there is anything we can do about steroids impacting on how the boys grow?
Yes, so thanks for the question, Emily. Boys with Duchenne, a large proportion of boys with Duchenne are short and don't grow so well. But the short stature is also interesting because prior to initiation of steroids in young boys with Duchenne, approximately 25% of children of these boys are already short. So we don't actually know why that is the case. So there might be an inherent defect as part of the whole spectrum of DMD, just like all of us are learning that there seem to be extended issues with like the brain and learning and behavior and autism in DMD. But no doubt, once steroids are started, we know very well that steroid treatment, especially at the doses that's used for Duchenne, impact growth by impacting the hormones controlling growth, but it also impacts on what we call the bones itself, which actually an area in the top end of all long bones called the growth plate. Okay, so these are known side effects of steroids. We know that growth impairment is worse in those, or there's greater amount of growth impairment in those on daily steroids as opposed to those 10 days on, 10 days off. However, I suppose at the moment there are some suggestions that daily steroids may be better for the muscles. We don't really have the full answers yet, and perhaps trials like the 4DMD trial, which most of you will be aware of, may help us shed some light on the sort of risk-benefit issue. Those criteria which are on the box in the standards of care about downward crossing of centile, height velocity, how much you grow in a year, and also height of less than third percentile, to be honest, I would say, and it suggests referral to endocrinologists. And actually, if you look at your own son, if he has been treated with, certainly at least in the daily steroid group for more than 2 years, all boys will satisfy that criteria, but not all boys are referred to the endocrinologist for a whole host of reasons. And you could ask to speak to an endocrinologist, and it suggests some of the testing that can be considered. The crux of it is that up till now, we don't actually have effective treatment for the poor growth and short stature in Duchenne's. Okay, the standards of care says that certainly growth hormone treatment should not be routinely recommended. There really is only one study from the American group of probably about 20 patients who were 20 boys were treated with growth hormone for about a year, and what they've noticed is that the amount the child grows increase over the year, but in fact, the child remains very short. Just because boys with Duchenne are very short, they are usually well below the lowest percentile. The curve may not be a straight line anymore. There may be an upward inflection, but the child is still very short. So that's something to consider. And secondly, there are some side effects in that study itself. We know that growth hormone, when used in conjunction with high-dose steroid, one of the common side effects is that it may lead to raised blood sugar, and some of those boys actually develop abnormal blood sugar or diabetes. So it is unclear that this should be used finally, a very UK-specific issue, and I know there may eventually be other non-UK people who listen to this webinar, is the fact that in the UK, there are very specific license indication for use of growth hormone, and the use of growth hormone in Duchenne muscular dystrophy is not licensed, and it is possible that the doctors may be, the general practitioners who prescribe the medicines may not actually prescribe it, or they're in the right not to prescribe it. So the point is that it is very common. We don't know why boys with Duchenne are short from the start, but following steroids is related to steroids. Not all of you have been referred to the endocrinologist because there's not good effective treatment, but if you do wish to speak to an endocrinologist to actually trash out these sort of risk-benefit questions, or whether things can be prescribed or not, you certainly could ask for a referral. Now, obviously, there are a few steroid-sparing medicines that are in clinical trial, and some of this look promising, and people like Duchenne UK are hoping to try to get these medicines quite quickly in the clinic, hopefully in the next couple of years, and perhaps that may actually alleviate some of the growth issues, if not completely eliminate it.
Okay, thanks so much for that, Jarod. We're going to move on to another issue now, and the impact of steroids on puberty. And again, I think there's a huge amount of variation across the UK and how this issue is dealt with, because high-level dosing of steroids does impact when boys go into puberty. Perhaps if you could explain why that is, and then again talk us through these various stages, and when you think the optimum time might be to consider taking something that can help induce puberty. So
puberty is very important for a whole host of issues. One is so on average, boys with healthy boys with no medical condition start puberty at approximately age 11.5 years, but it could be as late as 14 or just before 14, before we call it late, or the strict definition of delayed puberty is when there's no signs of testicular enlargement at the age of 14 years or older. High-dose steroids lead to the suppression of that of the signal that's produced by the pituitary gland. If you remember the picture we saw earlier, it makes a whole lot of signals, but it also makes signals which tells the testes to develop and tells the testes to make the male hormones testosterone. But steroids suppresses that signal. So again, it's not as if there's anything specifically wrong with the testes of boys with Duchenne, we think, but it's due to suppression of the hormone axis. And boys with Duchenne, particularly if you're taking daily steroids, by the age of 14, practically, even if you wait till the age of 14, almost universally puberty doesn't happen. Puberty is important for the self-esteem of a young person. Yes, there are physical changes, but also in the way they look and their voice. And I think that's kind of very important as our boys are growing up and trying to lead, and are in fact leading lives as like any other boy. It also leads to some degree of increase in growth rate, but very important as well is that, as most of you know, fracture and osteoporosis is very common in boys with Duchenne, and testosterone is a hormone, or male or sex hormones, in fact, actually help make bones stronger. And if we do not address delayed puberty, it is almost as if we're not addressing a factor which we could address to try to improve bone health. And that has been given attention properly for the first time in the 218 standards of care. And it is possible previously lots of boys have not had this checked or assessed. So what can we do? So the standards of care says that physical examination of puberty should happen from the age of 9 every 6 monthly, and I think that's not actually feasible. We are going through in the UK to try to identify things which we think are practical to implement in the UK, and I think what will most likely happen as we start implementing these recommendations is that there should be consideration, there should be examination of puberty if your son is on steroids from the age of about 12 years of age, ideally by somebody with with experience examining puberty, bearing in mind that there are service implications, and it is possible in the first year as we roll this out in centres where nobody has had their puberty examined, the doctors may need to see some of the older boys first to check that, to see they're okay. So what can we do? There are some tests which are recommended, and certainly if there's no signs of puberty by the age of 14, we can give some medicines in the form of testosterone. The standards of care says that it can be considered as young as 12, and that's probably reasonable, but I think majority of endocrinologists will probably be more comfortable starting testosterone from the age of about 13 rather than as young as 12, but that's in the standards of care. Testosterone can be given by a few methods, and again, specific to the UK, the medicines that we can get hold of commonly are injections into the thigh once every 4 weeks, and that generally is escalated every 6 months, usually till the boy finishes development over a period of about 3 years. There are also gels and creams that you can use. Tablets are not particularly very useful. In the US and other countries have different forms that we don't really have access to. So generally it's either injections or gels that can be used. So useful to address, and we certainly need to pay attention more into this area.
And Jarod, sorry to put you on the spot, but this issue has come up in our previous webinars about what patients should do about non-essential hospital appointments. And our understanding is that boys who are on testosterone who are given an injection, a monthly injection, do so at their GP surgery. What should patients do in that instance? Should they go into the surgery and have the injection if the surgery say that that's safe for them to do so, or would this be the sort of injection a parent could give at home, for instance?
Yeah, so I think that's something to just discuss with your individual centre, and also particularly with the neuromuscular clinician. My understanding that all boys with Duchenne should be shielded for the 12 weeks, and I'm not sure that is so crucial you want to take them out. In my centre, Emily, you're aware that I have swapped some boys who are on the injections to the gel, and the family are happy to give that a try. The gel is in a sense probably easier because it's a gel, but whereas the injections is monthly, the gel is daily. Some families, I suppose, if the family and if the clinician is happy for the family to be trained up, that's also another possibility. In some centres, I suppose some region district nurses may be happy to come into the area. We in our area, because we cover a different health board, there are some who are happy to do certain things and some who are not. And I didn't go down that route because I suppose it's difficult to see when staff will be redeployed to do different things anyway. So those are some of the possibilities with that. If there is a situation where it's not ideal, I suppose, and we did entertain that with at least one of our family, if there is no possibility of actually changing on to the alternative or another option, a couple of months without testosterone on the grand scale of things is not going to have a major impact on the health of the child. I think keeping the boy safe is much more important currently, but obviously we need to entertain all the other possibilities first.
Well, that's incredibly clear and helpful. Jarod, I think we've come to the end of the questions. So unless you have anything to add, we'd just like to say thank you so much for everything you're doing. We know that these are such uncertain, challenging times. And we want to thank you for all the work you do on behalf of our boys, and thank you for giving your time and your expertise today.
No, thank you very much, and everybody stay safe, and hopefully just not panic too much, as I think all of us have a tendency to, including doctors.
Well, thank you so much, Jarod, and you stay safe.
Thank you.
Thank you. So we'll just finish off with reminding everybody about these useful resources, the Duchenne emergency website, the family guide, which we took some snippets from today in our discussions with Jarod. Keep up to date with the government advice on the government website and the NHS website, the My Cortisol app, which Jarod referred to earlier, to help give guidance with emergency stress dosing of corticosteroids, and the World Duchenne Organization's website, which has webinars and useful information to help us through these challenging times. So if you have any questions that have arisen from today, or any new questions, then do please get in touch with us at support@DuchenneUK.org. We're planning a series of webinars every week to keep us all connected. The subjects don't have to be COVID-19 related, so if there's anything you'd like us to cover or understand more about, then do please get in touch. Thank you again so much for listening. Please do stay safe, stick to the government guidance, stay home, protect our NHS and save lives, and we will see you again next week. Thank you so much for joining.